and then we'll proceed to the Dr. Tang lecture, which we couldn't finish before this live case. And then after that, we'll go to his last live case from Dr. Sai. Sai is a good friend. He agreed to wait a little. Thank you, Sai. And now commissional alignment and post-TAVI PCI. You can disconnect Dr. Raj Center, Cedar Sinha. And commissional alignment and post-TAVI PCI, Dr. Gilbert and Tang, please. I think our sincere apologies, Dr. Tang, and sorry to keep you waiting, because live cases always get priority, because patients could be sick. Raj was waiting there. Thank you, Dr. Tang, for your waiting. Over to you, Dr. Tang, for your presentation.
We can hear you, Gilbert.
Okay, great. Thank you very much. No, I had to run to my own TAVI case. That's why I'm glad this timing worked out okay. I asked my team to kind of slow down a little bit so I can at least give the decent presentation. Can you see? Let me just make sure. Can you see the screen properly?
We are able to see your slides, sir. Go ahead.
Okay, great. Thank you very much. In the interest of time, I'll go quickly here so you don't end up finishing too late. So it's my pleasure and honor to be invited to talk about commissional alignment and post-TAVI PCI. Here are my disclosures. So we know that coronary access after TAVI can be challenging because a lot of the interventional cardiologists out there don't do TAVI and may not be familiar with devices. The aortic root can be highly variable in terms of anatomy. And unlike surgery, there are a number of barriers facing the coronary orifice after TAVI. So not just the aortic valve itself, but also the TAVI stent frame and also the commissural post if it's not aligned properly. Desktop, so maybe just from the Zoom. So anyway, my point here is just to quickly show that you can have a coronary access issue if there's a bulky leaflet facing on the coronary orifice, or if you don't have a lot of space in the sinotubular junction. So it's important to understand the different aortic root anatomy and the TAVR device type. So you can see that the shorter stent frame valves may be more amenable for coronary access, but still may be an issue for redo TAVR. But the taller stent frame valve may be relevant in both coronary access and redo TAVI, especially supraannular valve. So this is a paper my colleague, Dr. Sumin Sharma, Dr. Anupunakini, and myself put together a couple of years ago with the JACC paper review, talking about some of the anatomical and device procedural factors affecting coronary access. And you can see this paper from JACC Intervention showing the number of different parts of the transcatheter valve that can impact coronary access because it creates a barrier. So you can see that a commissural post is about 11 to 20% of the time that can potentially make it harder to access the coronary. This is an editorial that we wrote recently on TAVR and TAVR. So if you have two transcatheter valve, the commissural orientation of the first valve or the second valve matter depending on which valve you put in first and which valve you put in second. So that's kind of how we figure out in terms of, can we look at this in a more systematic manner to improve alignment with the TAVI valve? Because in surgery, we do it all the time. We don't try to overlap a commissural post with a coronary artery. There might be some early evidence, including ones presented by Cedars-Sinai, that might have impact on durability and gradient and halt with commissural misalignment. And if you have a situation where you want to consider basilica, you might not be able to do it because the commissural post is facing the coronary. So here's an example of what it looks like. So even for valve in valve, you can see a letter E and letter G from this paper. If your commissural post faces the split portion of the basilica device, you might still have a problem with accessing the coronary and coronary obstruction. This is a study that we published last year called Align TAVR. We looked at 3 different transcatheter valves. I'll just summarize the data very quickly. What we essentially did, we looked at over 800 patients, and with the balloon expandable valve, we crimped the SAPIEN 3 valve in different clock orientation to try to see if you can control the alignment. And with the Evolut valve, we changed the flush port to insert it at 3 o'clock rather than 12 o'clock before. And with the Accurate Neo, they also looked at the commissural orientation. What we found is that with the SAPIEN 3 valve, we're not able to consistently align the commissures with this system at this time. But with the Evolut system, the commissural post faces one of the C-tab. You can see that here. And when you deploy the valve, you'll see the hat marker as well. It positioned either outer curve or center front or inner curve. When you mount the envelope valve, you can see that the CTAP is actually 90 degrees clockwise from the head marker. So there's a mathematical relationship that you can follow during the deployment. How it works is that you can see that at the time of deployment with the head marker, majority of the time it's at the outer curve or center front when you deploy. Only a minority of the time it is in the inner curve or behind you. And as a result of that, majority of time, the CTAP will be at the inner curve ascending aorta, and that's what you want to accomplish to optimize commissural alignment. You don't want the CTAP to be at the outer curve or in the back or in the front. And you can see that with this bar graph, if you have the head marker, when you deploy the valve at the outer curve or center front, look at the green bars. The incidence overlapping with the coronary with the commissure is dramatically reduced compared to the red bars. So essentially what we've done now routinely is to insert the delivery system at 3 o'clock instead of 12 o'clock, so you're away from the operator, and to try to optimize the commissure alignment. And when that happens, what you notice in the classic or LAO view, the head marker will be outer curve, and then the cusp overlap view, the RAO portal will be in the center front facing view. So I'll show you a quick example. So this flush port, if you look at here, is located right here in the gray handle. And you try to put it away from you. So here's how it looks on fluoro. You can see the head marker tracking across the arch and the outer curve. And when you're ready to deploy your valve, your head marker will be either at the outer curve or center front, depending on which fluoro view you look at. And so when you release the valve, when you go back to a 3-cusp planar view, the CTAP will typically at the inner curve of the ascending aorta. And this patient had a post-CT looking at the commissure, so you can see it's quite well aligned. And in fact, this patient had a selective coronary angiogram done and was no issue at all. So now with from last year until now, I would say we've done over 250 cases, and the rate of getting the head marker to the outer curve or center front is 97%, compared to 70% before. And because of that, I would say the coronary interference with the commissure, you can see dramatically reduced in terms of the left main. The right also is quite a bit lower, although the right coronary is more variable, so it's more difficult. But both coronaries now down to less than 5%. There are some caveats. So this is only for transfemoral access. We haven't tested alternative access. And of course, we know that if it's a tortuous anatomy, calcified anatomy, it may be difficult to get the head marker to the outer curve. Also in this left femoral access. There are now other ways to perhaps align the commissure with other valves. So this is accurate neo valve. They are now doing some 3D printing to perhaps do a patient-specific anatomy to be able to align it properly. There are also a way perhaps with the portico system to try to do that. You can see this is the benchtop model testing it. And I would say this paper from the Denmark group, from Lars Sondergraf's group, looking at commissure alignment with the cusp overlap view to look at the commissural post, might be able to more consistently align the commissure with these 3 self-expanding valve, portico, accurate, and evolute. So I think in summary that current devices are not designed to achieve commissure alignment to facilitate coronary access. And I think it's going to be important in terms of lifetime management of these patients as the prosthetic valve degenerate or as the CAD progresses. What we found so far is that at least with techniques on deployment, we can improve the commissure alignment with the evolute system, but not so much with SAPIEN 3. But you can see that now the newer techniques and methodology, looking at CT-based or patient-specific ways to improve commissure alignment of devices. We still need to do a prospective study looking at coronary access after TAVR to really demonstrate that this matters with the commissure alignment and coronary access. And finally, we need to ask our manufacturers to really make valves and delivery system to achieve commissure alignment consistently, irrespective of the patient anatomy, rather than what we do right now, which is essentially like a Band-Aid method. So this app is designed by Dr. Annapurna and Dr. Shaneen Sharma with some of my input, looking at animations and coronary access after the balloon expandable and self-expanding valve here, the evolute. You can see the animations teaching people who are not TAVI experts to how to reaccess the coronary, and this is available for free on the Android and Apple platform, and also you can look at it online with a web-based teaching as well, that you can do it online, off and offline as well. So you don't even need internet once you get this program downloaded to you. So I'd like to thank you very much for the attention and the opportunity to present this, and apologize for the delay, and hope you have a good rest of the evening.
And thanks for sharing your experience. I think